Good morning. Today our guest speaker is Dr. Gaurav Prakash from PGI Chandigarh. He'll be speaking to us on precision medicine in lymphomas as a practice in India. This webinar is brought to you by Mumbai Hematology Group. It is supported by Roche, Natco, Lucien. It is managed by Perfect Square. I thank the team Roche, Natco, Lucien and Nirvin. Also thank Mr. Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest today, Dr. Rashmi Kushwaha from Lucknow. Our guest speaker, Dr. Gaurav Prakash. All our discussants were themselves hematologists or hemato-oncologists. You participants will spend your Sunday morning, afternoon, or evening, depending upon which part of the world you belong to. Next Saturday, evening 7 p.m. IST and Ohio time 9:30 a.m. Dr. Maddox will be speaking to us on follicular lymphoma advances and management in 2025. And next Sunday morning, that is 1st June, 11:30 a.m. IST, Dr. Satish Kumar from Bangalore will be speaking to us on BTKI in for the clinical hematologist from first to the third generation. Our discussants today, and we have a large number of hematologists, hemato-oncologists and medical oncologists from India and outside. Some of them are put up alphabetically here. Others who have showed their interest in becoming discussant yesterday and today are also welcome. A brief introduction of our guest speaker, Dr. Gaurav Prakash, MD Medicine, DM Medical Oncology, Professor in the Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. He did his MD in Internal Medicine from PGI itself. Following this, DM in Medical Oncology from AIIMS Delhi. He did observership in BMT from Cleveland Clinics, Ohio, BMT in Immunodeficiency Disorders from Children's Hospital, Los Angeles, and Medical Oncology from Washington, US. He is recipient of International Development and Education Award by ASCO. He has received innumerable other awards and distinctions as well. He is a member of various distinguished hematology and medical oncology societies and associations. He has published peer-reviewed articles in various national and international journals of repute. In addition, he has also written chapters in various books and monographs. He has participated in international conferences and presented oral and poster papers. He will be lecturing on precision medicine in lymphomas as a practice in India. Before that, it's my duty to introduce the special guest today, who is going to inaugurate our webinar and give some words of wisdom. And that is none other than Dr. Rashmi Kushwaha from Lucknow. Dr. Rashmi Kushwaha is professor and in charge, Hematopathology Unit, Department of Pathology at King George's Medical University, Lucknow. She is nodal officer for the antenatal thalassemia screening project by NHM. She completed MBBS in 2002, MD in pathology in 2007 from Rajiv Gandhi University of Health Sciences, Karnataka. She did senior residency from 2007 to 9 from Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi. She joined King George's Medical University in 2009. Since then, she is involved in teaching and training students doing MBBS, BDS, and MD pathology. Her areas of interest are bleeding disorders, hemoglobinopathies, and multiparametric FCL. She is founder member of UP Hematology Group. She is involved in various social outreach programs like hemophilia detection camps in various cities of UP every year from 2019 till date. She has conducted diagnostic camps for thalassemia and sickle cell anemia at Kheri district of UP in 2019-2023. She was awarded with Eminence in Research Award in Research Showcase, King George's Medical University in 2023. She has over 90 national and international publications and has co-authored Laboratory Manual for Laboratory Technique Training for State Institute of Health and Family Welfare, UP. She is actively involved in conducting various CMAs, workshops, and conferences. She's a member of various academic bodies: ICCS, ISLH, MNAMS, ISHBT, UPHG, MPAICON, DSH, IAPM, and IMA. I request her to inaugurate our today's webinar and give us some words of wisdom. Thank you, and over to her.
Thank you so much, sir, for the kind introduction. Good morning, everyone. I would like to thank Dr. M.B. Agarwal, Dr. Amit Khurana, and entire Mumbai Hematology Group for giving me an opportunity to be here as a chief guest. And I sincerely appreciate the effort put in by Mumbai Hematology Group and Dr. M.B. Agarwal, Dr. Amit Khurana for organizing these webinars every weekend and giving a chance to the young students, faculty members to interact with the knowledgeable faculty, not only from India, but across the world. And I'm sure even today's session is being attended by many students from India as well as across the world. And in this series, we have a talk today by Dr. Gaurav Prakash. He'll be talking about the precision medicine in lymphomas. So if you talk about hematology, it's a beautiful amalgamation or combination of hematopathology, where you deal with the diagnosis of the disease entities, and clinical hematology, where you treat. So it's a complete bench to bedside branch. If you talk about hematopathology, earlier we had only few ancillary techniques like bone marrow, peripheral blood, or CBC. But today we have entire spectrum of diagnostic modalities available. Like you can use IHC, you can use multiparametric flow cytometry, you can use molecular cytogenetics or NGS. So diagnosis has become more precise. Not only diagnosis, you can prognosticate the disease as well. You can monitor the disease by doing MRD with any of these techniques. Similarly, the treatment modalities have progressed from leaps and bounds. Now you can use the monospecific antibodies, the bispecific antibodies, the CAR T cells, the CAR T cell therapy is being developed at many centers these days, and CRISPR technology. So both hematopathology and clinical hematology have developed a lot in the last few years. So you can take up, as a student, you can take up either hematopathology or clinical hematology. And I can say both these branches have a very promising career ahead. So as a student, if you are aspiring to take up these branches, then there are many institutes which are offering DM courses, the PDCC courses, the fellowship courses in India. And there are these fellowship courses available across the world also. Not only in the patient care, there is a lot of research happening, lot of innovations coming up in this field. So you can take up the research aspect also. So it's like before inaugurating the session, I would like to suggest few guiding principles to the student. Always stay curious, since hematology is a rapidly developing branch with many recent innovations happening. You have to read, you have to keep yourself updated, attend seminars, webinars, and keep yourself updated. You have to stay compassionate towards the patient. Behind every patient, behind every report, I can say there is a patient, a person with dreams, hopes, responsibilities. So you have to take utmost care for your patient in diagnosing as well as treating. Always value teamwork. You have to respect your colleagues, your faculty members, your nurses, the ward boys, and the lab technicians, because a good teamwork leads to a success. Take care of yourself. It's a very demanding branch with a long hours of duty, you can say. So you have to take care of your physical health, the mental health, and emotional health. Because as a doctor, if you are healthy, then only you can take care of your patients. Be ethical and humble. Let your actions be guided by integrity and humility and respect for your patient. This is very much important. So with these words, I formally inaugurate today's session, and I would like to hand over the session to Dr. M.B. Agarwal for further proceedings. Thank you so much, sir.
Thank you, Dr. Rashmi, for those golden words. You have crafted your speech so beautifully. You are right that so much of sweat and blood goes behind every diagnosis and the treatment. The responsibility of medical people is immense, and though it is appreciated, but somehow it is not that well appreciated in India. The hard work is tremendous, and today we have Dr. Gaurav Prakash, who has focused his work both in clinical practice and research in lymphomas, And I'm sure that after another 5 years, he'll be practicing maybe one type of lymphoma. So today we are going to hear from him what will be very, very educative to all of us. Over to Gaurav Prakash.
Madam Chairperson, Professor M.B. Agrawal, and the entire Mumbai Hematology Group. Thank you very much for giving me this opportunity to interact with all the students and discuss my thoughts on this unique topic. Just all right. Thank you. Right. So I think the theme of this lecture is not DLBCL or lymphoma per se. The theme is precision medicine. If we try to understand that what do really we mean by precision medicine, or also called as personalized medicine, it will help us interpret the current data and results with respect to treatment of lymphoma. Given the heterogeneity of so many lymphomas, I have focused the discussion on DLBCL where the maximum action is happening. So the tenets of precision medicines are who, how, what, when, and when not. The when not is very, very important. Before understanding precision medicine, let's have a look at conventional medicine. Now, conventional medicine is something where medical treatments are designed for a general patient, an average patient, and the most common patient, because that will make the largest denominator. We can say that it works on one size fits all. Mostly it works on fixed doses or fixed dose rate. And as a result, because the attempt and the focus is average results are achieved. Now, average is not a bad word because when the resources are limited, you have to find solution for maximum number of patients, and that is where conventional medicine wins. Some examples are here, like 4-drug ATT. So you take any patient with pulmonary TB, bone TB, lymph node TB, it is the 4 same drugs almost in fixed doses. This is something conventional medicine teaches us, and so is our job. Now, when we have a look at the precision medicine, now the basic point is that it approaches a patient considering differences in the people's gene, environment, and their lifestyles. It was interesting to read this. So then I thought, if there is a patient or person who is going on expedition to Mount Everest and you give him acetazolamide, Diamox tablet to reduce the intracranial pressure, then this is a kind of precision medicine. So precision medicine relies on right treatment to right patient at the right time and in right doses. When we apply precision medicine in the field of oncology, hematology, then we have two basic tenets. Number one, there has to be a target. And if a target is not present, there has to be a very robust biomarker. Before we go on the precision medicine, let's take a travel down the memory lane. It was 1971 when first multi-agent chemotherapy, which is CVP, came for lymphoma. Before that, it used to be some single agent therapy here and there or radiation. And in 1973, the paper of CHOP chemotherapy was published. If you see on this slide, from 1970s to early 2000, it was all CHOP. It changed in year 2002 when then this elegant LNH98 trial was published, CHOP versus R-CHOP in elderly DLBCL, significant around 14% improvement in CR rate, both overall and event-free survival improved. Published in NEJM, path-breaking study, it changed the way we used to treat DLBCL. The same was substantiated in year 2006 and 8 by Michael Fronshu from Europe, where R-CHOP was given for younger DLBCL, MINT study, similar results. And they also tested 6 versus 8 R-CHOP. Earlier, I remember when I started, those patients who were responding used to receive 8 CHOP therapy because probably that's the best we could do. But this trial settled that only 6 R-CHOPs are sufficient. After that, Again, there is a lull for 2 decades. From 2000 to 2020s, it is R-CHOP. Now, if you see R-CHOP, not a bad drug combination, in early stage runaway success, around 90% patients of early stage DLBCL are cured. But if you speak of advanced patient with poor markers, this number is very humbling, only 21% with R-CHOP. So if we can take an average, around only 55 to 60% patient will be cured today with R-CHOP therapy. We can look at it as a success also, but if you think from the side of those 40-45% who were not cured or relapsed, it becomes very difficult. So therefore, while R-CHOP is a great success, but it refused to inch further. DLBCL has remained stubbornly refractory to any new interventions, and I will share some interventions with you. There are multiple well-designed attempts to improve R-CHOP outcomes over last 20 years. Now let us have a look at those strategies. The first one and the most common one is conventional chemotherapy, because at one point in time, that is all we had. People tried R-CHOP 14, Maxi R-CHOP, EPOCH-R, dose-adjusted EPOCH-R, or ABCVP. Now, the last one in the list is again an LNS trial, which showed significant OS and PFS benefit. I think the only combination which showed in a randomized fashion OS and PFS benefit, but it was very, very toxic, and probably the main author of this study also do not use it. The second one is DA EPOCH-R, and there is a lot of buzz around this, and later part of presentation, today's presentation, I will discuss this point. The second strategy, which is more towards precision oncology or hematology, is R-CHOP plus X strategy. And the notable X is R-LEN, bortezomib, and ibrutinib. Because I am focusing how would I interpret precision oncology in India, so therefore I have focused on these three. Scientists also tried to use various maintenance strategies to improve DLBCL, rituximab maintenance, LEN maintenance, everolimus, and zosterin. Largely, none of them improved survival. There is one paper for lenalidomide that it improves PFS, but not OS. However, because of toxicity and other concerns, it also did not see light of the day. And the latest one is newer anti-B-cell antibodies. We have Gazyva or obinutuzumab, and the latest kit on the block is polatuzumab, Pola-RCHP, the famous POLARIX trial. Now, again, from this background, let's have a look at first genetic or precision approach towards DLBCL. Before that, anything which used to be a large B-cell lymphoma used to be called as DLBCL. But cell of origin gave us some idea about the molecular and then immunohistochemical profile of DLBCL. We all are very well versed with these three terminology: germinal center B cell, activated B cell, and a very small number like 10% who cannot be classified between the two are called unclassified DLBCL or type 3. Now you can see distinctly genetic signature. If IgH and BCL2 translocation is the main driving force behind germinal center B cell, and IRF4 MUM1, CARD11, TRF2. I have highlighted them here because later part of my presentation, you will see that the drugs that I spoke about are particularly targeted on this. Therefore, those humble drugs are also a part of precision medicine. This is the journey of a B cell. Initially, there is a pre-germinal center naive cell. It undergoes IGVH hypermutation, enter germinal center, antigen is presented. A large number of somatic hypermutation takes place. And after these hypermutation, this cell becomes armed to fight infections and produce specific antibodies, and then it is released. So you can see at this phase, it gives rise to GCB type of DLBCL. Once it is more active, more robust, it gives rise to activated B cell type of DLBCL. So what we know about cell of origin, we know that it is a subtype. These two subtypes have distinct signature, three subtypes, and ABC has poor outcome in comparison to GCB. These two Kaplan-Meier curves are testimony to that. The orange one is GCB and the blue one is activated B cell, progression-free and overall survivor way below the GCB subtype. Now, what can we do about it, or what do we not know? That is whether precision medicine can bridge this gap. Let us see. So the conundrum of cell of origin is it was discovered using highly complex gene expression profiling. And Affymetrix is the company which made this very broad microarray. And with the help of this Affymetrix array, in certain research lab, we could get GEP. Scientists found out a easier way, which is Hans algorithm, ISC. And this is the most widely used algorithm. There are 5 and 6 more different algorithms using various ISCs, which can help us in distinguishing the cell of origin. However, there is a wide variation in reproducibility of these algorithms. In one laboratory, they will say it is activated B cell, but the same sample can very easily be labeled as GCP. So therefore, currently scientists are coming to a truncated form of this Affymetrix microarray, which is lymph2CX. And with the help of this, probably in times to come, cell of origin may become easier on the basis of GEP. Now, these are the molecular signature of cell of origin. I spoke about CARD11, inactivated B cell. You can see various cell signaling pathway. And the other one is MUM1-IRF4. So in IRF4, the most active drug is lenalidomide. And if you see here, IK kappa inhibitor, proteasome inhibitor, nadylation inhibitor, Bruton tyrosine kinase, common name, Lin, SYK, and PKC inhibitor. So while we have proteasome, BTK, and lenalidomide with us, but these all inhibitors are undergoing trials, and some of them will see light of the day. After the cell of origin, the second step towards precision medicine in DLBCL was development of these fish-based classification, double hit and double expressor DLBCL. Now, if you see this table closely, this is a very informative table. So double hit and triple hit lymphoma are listed. They are almost clubbed together because their behavior as well as outcomes are quite similar to each other. The basis of double hit is 2 hits, MYC and BCL2 rearrange. I would want to tell the students that if there is a rearrangement between MYC and BCL6, it is not called double hit lymphoma because the outcome of these patients is significantly better. Luckily for us, only 6 to 8% of all DLBCL will have double hit lymphoma, and almost all of them will be GCB subtype. They are more resistant to therapy, and intensification of therapy may help, and we will see some evidence towards this. Triple hit is almost identical to double hit, except that it also involves BCL6, and it has more extranodal disease. Rest, everything is same as double hit lymphoma. Now, double expressor, while it looks like a close cousin of double hit lymphoma, but it is not, because by definition, it has to be negative for MYC and BCL2 rearrangements, but then it has to express on IHC MYC, which has to be more than 40% staining, and BCL2 more than 50% staining. It makes a sizable chunk of DLBCL. Around 1/3 of all DLBCL will have double expressor lymphoma. Most of them will be activated B cell type, and they have poorer outcome. So double expressor is situated between, so double hit is poorest, general DLBCL is here, and double hit expressor is somewhere in between. One key point is, if you have double expressor, while the innate desire will be to give more intensive therapy, but the good randomized studies have shown that intensification of chemotherapy does not help. And this is that paper where DA-EPOCH-R was compared with R-CHOP in frontline therapy. This was a large phase 3 alliance group from the Eastern America, 50303 study published in JCO. Now, if you see, again, a very humbling experience, DA-EPOCH-R and R-CHOP, they have almost similar overall survival. PFS was slightly better in DA-EPOCH-R, but then ultimately that was also not significant. I took a look at the subgroup analysis, and if you see double expressor, they have not reported double hit lymphoma in this paper. Only double expressor lymphoma is reported. So if the patient is having double expressor lymphoma, the benefit, it was equivocal whether you treat with R-CHOP or DA-EPOCH-R. The outcomes were almost similar. It was not favoring any one regimen over the other. So why to give the trouble of giving DA-EPOCH-R for 5 days and giving more toxicity? R-CHOP is a way to go. So if R-CHOP is a way to go, then what about double hit lymphoma? Now, double hit lymphoma, if you ask off record with anyone, most of us are dissatisfied with R-CHOP. So we said, okay, DA-EPOCH-R is way to go. Now let us see what is the supportive evidence for DA-EPOCH-R as a targeted therapy. I call it targeted because we are personalizing for double hit lymphoma. The evidence comes from a retrospective study from multiple centers in Italy. Reasonably large number, 114 for double hit lymphoma, because double hit is only 6% of all DLBCL. So large, okay number. So they almost equally allocated, not allocated, but retrospectively found 51 patient DA POCAR and 63 RCHOP. And for PFS, you can see 54 versus 62%. There was benefit. And if you see overall survival, 70 versus 85%. So overall survival benefit of 15% looks significant. This difference was seen in only patients who were younger than 65, but there were caveats. It was a retrospective data. There can be a huge selection bias. If you ask me, I will choose a much fitter patient to receive DA EPOCAR. Otherwise, I will tell my team, this patient is not fit, you give RCHOP therapy. The second is, in this paper, RCHOP patients were treated in older times because it is retrospective. So older patient RCHOP data was taken out for comparison with the recent data of DA EPOCAR. So that brings it another kind of bias. However, this is the best evidence that we have for DA EPOCAR today. And on the basis of this, most of us use DA EPOCAR in patients who are having poor risk DLBCL, especially double hit. So now we have seen double expressor, double hit. Now I would want to bring your attention to this very interesting point called BCL2 riddle. In my initial presentation, I told that double hit lymphoma is like BCL2 is rearranged. For double expressor, BCL2 has to be more than 50%. Now, BCL2 seems to be the main target. And today we have a great drug which is making wonders in the field of hematology, and it targets BCL2, it is venetoclax. So a natural innate desire will come that, use this drug. It has made, inroads into AML, transformed lives of multiple AML patients where there is no BCL2 per se. Here we have a disease which expresses BCL2 left and right. So why not here? The same thought was taken by scientists much before us, and they randomized DA EPOCAR with venetoclax and DA EPOCAR with placebo. It came with fanfare with Alliance Group, presented as poster, but if you see, there was excess treatment-related mortality, not morbidity, mortality. Patient died who received DA EPOCAR with venetoclax. So therefore, this trial was curtailed before completion. You will never see a full paper because it was stopped. And if you see, the top solid bar is only DA EPOCAR. And when venetoclax was added to this, you can see the rapid decline in survival. Both PFS and OS were poor. So I think a humbling experience for us. We had a great target. We had a great drug which can hit that target, but still when we used in the real life, it led to more deaths. Probably we still do not know how to use venetoclax in DLBCL. And in the times to come, somebody will find out one way or other, or maybe we can also try to find it out. Okay, so we have seen now cell of origin, double hit, triple hit, and double expressor lymphoma. Now, this is a third basis of precision oncology in the field of DLBCL, which is genetics. The basis of current oncogenetics is next generation sequencing, and we know it is the foundation for DLBCL as well. This next generation sequencing is high throughput sequencing. It rapidly sequences large number of DNA fragments. It is both fast and cost effective. On the basis when we are armed with this new tool, and it is working in almost every tumor, so why DLBCL should be behind? The NGS has changed taxonomy of DLBCL. Now, the DLBCL subtypes are distinguished on the basis of various targetable genes or putative genes, if not targetable. It has affected the way we approach classification of patients with DLBCL. It is my gut feeling that in years to come, DLBCL will disintegrate. It will disintegrate into large B-cell lymphoma with particular subtypes. The way AML with PML-RAR alpha is now APL. So AML with PML IZKF is a different subvariant of APL. We are going to see probably DLBCL, but if the pathologists decide, and the chairperson, madam, can tell me that they may retain DLBCL and they just make subclasses within this umbrella. The initial subclasses reported for DLBCL were only 4, labeled MCD, BN2, N1, and EZH2. Now, these names are not just fancy, they represent the genes. Like MCD stand for M stand for MYD88 and CD is for CD79 A and B. BN2, B stand for BCL6 and N2 is notch 2. N1 is notch 1 and EZH2 is EZH2 gene mutation. It is also called, later it was modified and it's called EZB, which is EZH2 and BCL2. And on this side, you can see that there is a good mix of both ABC and GCB subtype. So therefore, this classification is now fading away and people are focusing on these genetic subtypes. This is an older concept where when we had only 4 genetic subtypes. Now what happened? A new algorithm is proposed by hematopathologist and it is called lymph gene algorithm. I will show you the students few glimpses about it. After this algorithm, now we have 7 classes of DLBCL to make our life much difficult. It was already difficult, it will be more difficult now. And you can see this in this Shanky diagram, there is a class switch from ABC. So now this ABC is a patient who used to be uniform ABC, now they are part of 7 different groups. Similarly, GCB also is now contributing to so many different genetic groups. This is how lymph gene algorithm work. Please do not be stressed not to remember this. I'm just going to show you the complexity of this algorithm, how we reach this classification. So they take every patient's biopsy. This is one DLBCL biopsy, and they run long sequence NGS. After that, for example, in this case, they studied for EZB subtype. So these are various genes which are known to, because of gene expression profiling, are known to be expressed or mutated together. And then they had a score for each gene, like what is the EZB likelihood score or non-likelihood score if EZB is not there. So you can see L number is there, L14, M14 number is there. Now they have this complex mathematical formula. And after this small mathematical formula, they reach a probability number, P number, which is P subtype, this divided by this. And that is how, after this very complex calculation, we will know whether we are having MCD, N1, A53, BN2, so far, so forth. Now I will take you back from the realms of genetics because most of us are clinicians here. It is all these things make us jittery. If you see the prevalence and survival between these genetic subtypes, so most common subtype or prevalence is luckily for EZB. And if you see EZB, the survival, if MYC is negative, is 82%, 5-year survival, remark almost curable. But if MYC is present, it is only 48. So if you see other subtypes, then these lower types like EZB, ST2, BN2, they all have good prognosis because they have fairer share of GCB subtype. But if you see the top class, MCD, N1 and A53, the survival is 30, 40%, 20%, 5-year survival, which is very concerning. And here also 33% for activated B cell type. But in this subset, if it is GCB, it is a very good survival. In the third column, you can see various potential targets. Today, we do not have many drugs which can target all of them, but then some of them are available and we will see them. The question is, how can we utilize whatever I told you in terms of molecular classification of DLBCL? The rider is that our choices today are limited by the drugs that we have available in India and the number of clinical trials which are accruing patient for these genetic subtype in India, which to my knowledge today is none. Now you see this diagram, very complex and it makes me nervous, but you can, it is just to show you the hope that so many drugs which are written in red, they are either approved under trial or being considered to have precision medicine active in the field of DLBCL. I will start with the humble drug and favorite drug of hematologist, which is lenalidomide. And you know the robust trial, the most famous trial, R-square-CHOP versus R-CHOP 21. This trial only took patient who had activated B-cell DLBCL. This was published in JCO. Good trial, phase 3, 570 patient. And these patients receive R-CHOP plus 15 mg of lenalidomide for 15 days. The other arm receive only R-CHOP therapy. Now, if you see R-square-CHOP and R-CHOP, both PFS and OS probability was almost overlapping. R-CHOP was slightly better, but this difference was not statistically significant. On the other hand, without giving much benefit, this combination was more toxic than R-CHOP chemotherapy. Now, a phase 3 trial showed that it doesn't work. Very interestingly, in the same issue and by the same author, another paper was published. So 2 papers were published back to back in the same journal. And in this, they showed that R-square CHOP was significantly better than R-CHOP chemotherapy. This was Akrin E1412 trial. Now, Nowakowski was the author of Robust trial also and this trial also, R-square CHOP versus R-CHOP. If you see 3-year PFS and 3-year OS, OS and PFS benefit if you give R-square CHOP. So now, like all of you, I was also confused now what to do, which one to believe. So let's take a critical analysis of these 2 trials. Now, Robust trial, the initial one, was a phase 3 randomized controlled trial, while Akrin trial, which showed benefit, was a phase 2 randomized study. Now, if you see Robust trial, it was adequately powered to find difference between the 2 subsite, but phase 2 randomized is relatively underpowered. Population, Robust trial took patient only activated B cell type, but Akrin trial involved all DLB cell patient. Therefore, GCB was also included. As a result, it showed no benefit, but it showed survival advantage. So I leave it to the judgment of all of you which one to believe, but the feelings are mixed. The interpretation is because of contribution of GCB patients in Akrin trial, some survival advantage might have been observed in Akrin trial, but addition of lenalidomide was more toxic. Now, second target is proteasome inhibitor, which is in this CARD11 pathway. Again, a very great trial, Remodel B, which is VR-CHOP was compared with R-CHOP 21. Good number of patients, around 460 patients in each. Bortezomib, only 2 shots were given, 1.3 milligram standard dose of bortezomib. And this classification was on the basis of gene expression profiling. So really robust study published in Lancet Oncology. And the conclusion was that RB-CHOP, although graph is looking slightly above from the beginning, but this difference was not statistically significant. So therefore, it fell out of favor. However, they found that VR-CHOP was not more toxic than R-CHOP chemotherapy. So in CARD11 pathway, proteasome inhibition is also not very effective. There are some smaller studies with carfilzomib as well, but their conclusion is also the same. The last in this series is targeting BTK, Bruton tyrosine kinase inhibitor. A very famous study, Phoenix study, was published, and they focused only on non-GCB or activated B cell type of DLBCL. Now, in this study, patients who were less than 60, they showed significant EFS, PFS, and OS advantage. In this subset, the toxicity of IR-CHOP was well manageable. But it has a caveat that though in this trial, patients who were more than 60 or infirm, ibrutinib with R-CHOP was associated with increased toxicity and did not improve survival. These statements can be better appreciated in this graph. So if you see younger patient, the EFS and OS both are way, way better. But if you see patient older than 60, the difference was not at all existent. Rather, ibrutinib R-CHOP was inferior. So therefore, it was concluded that if you have a patient who is young, no cardiac comorbidity, poor risk ABC, probably IR-CHOP can be given. Now I'm moving towards very quickly to role of newer anti-B cell monoclonal antibodies. This is a type of precision medicine also. One may debate it, but then as this is what the best we have today. Rituximab is like field day. All of us use it left, right, center, and there is no doubt about its efficacy. So came the newer kids on the block, obinutuzumab, which is Gazyva. So Goya trial, it started with a fanfare. We all were hoping a lot with this trial, G-CHOP, but it showed that there is no advantage. If you see R-CHOP, G-CHOP, identical graphs, no benefit. And if you see ABC subtype of DLBCL, where we want newer drugs to work, it did not work. So it was very, very dissatisfying. So after that, nobody talks about Goya trial. Then came polatuzumab vedotin, which is anti-CD79B. Now, obinutuzumab and rituximab, they are naked antibodies, and this is antibody drug conjugate, where vedotin is monomethyl auristatin E, and it is likely to be more effective. and the trial is Polarix. In this, they found significant benefit. The patient who were high risk, defined by IPI 3 to 5 and high stage 3 and 4, they demonstrated overall 6.5% progression-free survival benefit and lower risk of death, relapse, and progression. Contrary to the ibrutinib study, the greatest benefit of polatuzumab was seen in older individual, which is the problem area for most of us, more than 16-year-old individual with DLBCL and who had activated B cell type, who have high IPI. This was a cohort which benefited the most with POLA-R-CHP. And these are the survival curve you can see. Here it is progression-free survival, and here it is event-free survival. And both were significantly better in POLA-R-CHP. A glimpse in what may come in future. We already have data for CD30 positive DLBCL, where brentuximab vedotin is being used, can be used, although this population, this cohort is very small. Now, CD38 monoclonal antibody daratumumab, it is being tested in relapsed refractory DLBCL. It is going to target this particular molecule, and it has some immunomodulatory effect, which I still have to read more and understand. Now, anti-CD22 antibody is epratuzumab, again in early trials. CD52 monoclonal antibody alemtuzumab. We know it well for TPLL and or other T-cell lymphoma, but then some role is emerging in relapsed refractory DLBCL. And last and newer one is CD40 antibody, desituzumab. Again, this is under the initial trials. So this is just to show you the glimpses that how these particular targets are going to modify the way we treat DLBCL in times to come. As of now, none of them is prime time. Immune checkpoint inhibitors, we cannot run away from them before we conclude. If those who practice solid tumor oncology also, they have some idea, they understand that immunogenic tumor like RCC, hepatocellular carcinoma, lung cancer, these agents have made remarkable differences because of innate immunogenic nature of those tumors. And these are tumor agnostic therapies. They do not look at the tumor. They just look at whether T cells are available to kill the tumor or not, or whether they express PD-L1, which we can program. So luckily, we have this group of tumor agnostic immune checkpoint inhibitor, relatively safer drugs. Now, if you see, there are so many trials, nivolumab, pembrolizumab, pembrolizumab with rituximab, pembrolizumab with a CAR-T, which is tisagenlecleucel. Now, as of now, all of these trials are for relapsed refractory DLBCL. We have none for frontline, and some of them have reported ORR and CR also. Today, they look not great. The response rate is 10%, 3%. Here in nivolumab is 26% and CR rate is 18%. So probably in DLBCL, we are not getting much traction with immune checkpoint inhibitor. And the reason is because DLBCL, unlike Hodgkin lymphoma, is a very uniform tumor, which has very, very little T cell infiltration. Hodgkin malignant cell are 2%. It is filled with various kind of lymphocytes. So immune checkpoint inhibitor have great opportunity to train those lymphocytes against the tumor. And it is a great success in Hodgkin lymphoma. But DLBCL is diffuse B cell, sheets of B cell with nothing in between. That may be one of the reasons why these fantastic drugs did not work in the field of DLBCL. Before I conclude, to the students, this is not to remember or read, just to glimpses in the future. Now, AI is everywhere, in our paper writing, presentations, and whatnot. So AI is here as well. This is a Chinese paper, and where they are developing precision models, and they are not using genomics. Whatever I spoke to you about was either on the basis of genomics or genetic-based classification, but they are talking of multi-omics, spatial multi-omics approaches for diffuse large B-cell lymphoma. And to give you glimpses in this field, panel A and B is the current story. A patient comes, there is a lymph node. Within the lymph node, there is lymphoma. Patient is admitted, patient has B symptoms. You do a biopsy, and after biopsy, you give R-CHOP. You attack with R-CHOP. Everybody is attacked with R-CHOP. They develop toxicity, you manage toxicity. Half of them are cured, but half of them will relapse. When they relapse, we have various options, but truly nothing is great option for early relapse of DLBCL. This is today's story. But panel C is that multi-omic approach. In multi-omic approach, they take genomics, expression profiling, metabolomics, proteomics, and on the basis of that, they create an individualized treatment plan and go towards a precise cure. So here you can see 4 omics coming together: genomics, transcriptomics, proteomics, and metabolomics. All of them are being combined with the help of artificial intelligence. And I will show you how they are combining it. So for any tumor, this is not for DLBCL, for any tumor, they take these 4 parameters, these 4 omics. They do data integration and do a very, very exhaustive artificial intelligence analysis, data acquisition, processing, and analysis. After that, they remove replication, false positive, because if you do huge analysis, there is bound to be errors. So check balances are there. They remove all these. And after that, they do interpretation and find biological relevance. This is the direction, ladies and gentlemen, the field is moving. And it is also being done in the field of DLBCL. I will show you last example. So IPI is something we all know for last 3 decades. Now there is a new model called contain model, which is MCPM. And so IPI we apply left, right, and center. But for MCPM, there is again AI-based model. So in this artificial intelligence-based prognostic model, how it is done. So this, on one side you see IPI, and this is the future. They say they take multiple features up to feature X, then take multiple genetic markers. Then they acquire this data, they do training, validation. Then they have this logarithmic score. And after that, the final thing is they give us in an individual patient OS and PFS probability. A time may come where a patient walks in, we enter the report of the patient, and while the patient is being discussing the treatment, we will give individual OS and PFS probability when these models become more refined and more ready to use at the point of care. And this is the graph from the same model. So coming towards conclusion, the more I read about it, the more I try to understand, I become more confused. Precision medicine is a tough topic. This book makes me uncomfortable, but then the whole field of medicine, especially hemato-oncology, is like that. The future circle of medicine will be like this. Step 1, you collect patient's material, either blood or biopsy, depending on type of tumor. You do risk stratification on the basis of advanced tumor profiling. After that, you have a customized treatment plan. You administer it. Most patients are likely to benefit from it. Some of them will see a relapse or will maybe refractory. And after that, so at the time of relapse, we know so many more genetic mutations might have accumulated. So you repeat the step 1 and the cycle goes on. I will conclude with the last part of the topic today. How will I use this data to treat a patient today? So this is my personal thought also. A newly diagnosed DLBCL, if it is double hit or triple hit, then we go for intensive chemotherapy. This data is backed by retrospective analysis, but this is the best we have today. So if the patient is fit and younger, you deliver it. But if double hit and triple hit is not there, then for early stage, we are good. 4 cycles of R-CHOP chemotherapy are sufficient. LYSA trial data is there. If required, give radiotherapy, IFRT. But if the patient is not having early stage lymphoma, then look for IPS, IPI. If IPI or other poor risk marker are there, then POLA-R-CHP definitely helps patient who have poor risk DLBCL or if the patient is elderly. But if high risk features are not there, then R-CHOP is useful. Honorable mention is ibrutinib R-CHOP if the patient is younger and ABC subtype. So if the patient is older, maybe POLA R-CHOP can help. But for younger patient and who is not having other poor risk marker and ABC subtype, then IR-CHOP is a reasonable mention because it has shown overall survival benefit also. Lastly, I always consider CNS prophylaxis, 3 subset. If CNS IPI is 4, 5, 6, patient has testicular, adrenal, or bone marrow lymphoma, or multiple extranodal sites are involved. How do I deliver it? There are 2 ways. Number one, you use high-dose methotrexate, 2-cycle intercalated between RCHOP. Or if you cannot do that because of logistic reasons or toxicity, because SDMTX is toxic, you can just give 4 to 6 doses of intrathecal methotrexate. With this, I thank all of you and hand it over to the Mumbai Hematology Group and Agrawal sir.
Thank you, Gaurav. Wonderful talk. Enjoyed listening to you. Very innovative thoughts also. You have put the data together in a very fascinating way and a reasonably simplistic way for a student to understand. And I think all of us, including aged and young, followed you reasonably well. So we will have some discussion. Probably we will use the raise hand sign. May I ask you something till I see the first raise hand sign? The question I have is about your CNS scoring and prophylactic CNS therapy. Recently, last couple of years, there is data that all this has made no difference in the incidence of CNS involvement as relapse setting occurs to the same extent. So, except probably for testicular, that apart, other patients, do you feel that one should continue to give CNS prophylaxis or it does not make a difference? Number two, does intrathecal methotrexate make a difference because these are parenchymatous involvement? So does that really help? Number three, intercalating methotrexate high dose, will it be very detrimental to the timing of the next RCHOP and would in the long term interfere with the cure rate? So 3 questions in one.
Yes, sir. Thank you. All 3 are tough questions. So in ASH 23, this paper was, I think it was a late breaking abstract. It was published where CNS prophylaxis using high-dose methotrexate was compared with the intrathecal methotrexate, and it did not find a very clear benefit of giving high-dose methotrexate. However, what we know that these patients who relapse in CNS, they have very, very worse outcome. So most of us and most lymphoma doctor, they favor using a high dose, a prophylaxis for CNS relapse in the future. Now, evidence has shown, sir, that intrathecal methotrexate also helps reducing the risk of CNS relapse in the future. The difference is not much. So does high dose methotrexate. The way I deliver, and most it is written in the literature, that maybe it's in cycle 2 and cycle 5, cycle 3 or cycle 5. You give cycle 3 or 2, and immediately from day 5 start growth factor. By day 10, counts will be up. On day 10, you admit the patient, give high-dose methotrexate, and from day 11 or 12, you start GCSF, so that by day 21 of next cycle, your counts are up and you can give it. It looks very simple, but it is very difficult to do, especially if you have a very busy practice and public sector hospital where bed crunch is there. But then I am a proponent of CNS prophylaxis. There can be valid arguments against it, but intrathecal methotrexate is something we have in our hospital. We have developed a separate intrathecal room where very easily it can be administered. So if these parameters are there, we administer, sir.
Thank you. Still waiting for the raise hand sign. Yes, Dr. Sangeeta Koti.
Hello.
Yeah, go ahead, Dr. Sangeeta.
Yeah. So thank you very much, Dr. Gaurav, for the comprehensive and engaging presentation. So my question is, in this era where multiple new targets, multiple new drugs are coming, where do you keep the role or the place of consolidative radiotherapy, especially in advanced DLBCL?
Yeah. So consolidative radiotherapy is the role is very well defined. If you have a bulky tumor, which is for DLBCL defined by size more than 7.5 centimeter in the largest horizontal diameter, then even after CR, you give consolidative radiotherapy. I will give you 2 arguments behind it. Number one, I think all of us unanimously agree that the best chance to treat a tumor in our country is at the time of first treatment. And the second one is focused radiotherapy is not associated with very, very severe toxicity unless it is located at very vital organ. So therefore, you have to consolidate in any patient with a bulky disease.
Yeah, so
Or residual solitary, or residual solitary. If you have after R-CHOP 6, there is a solitary
Yeah.
small mass, then you consolidate.
Right. So especially in advanced disease, when a patient, for example, has multiple extranodal sites where the chance of disseminated relapse is high, do you still consider? I'm asking this because there is very much difference in opinion of medical oncologists. Some say, I mean, it's just adding another treatment modality when you know that the patient already has a lot of extranodal sites. So what is your treatment policy in those situations?
So if the multiple extranodal site involvement is a part of the so-called triple hit lymphoma, then anyway, these patients have very poor outcome because of their genetic signature they have. But otherwise, we do not distinguish between a bulky disease in nodal and extranodal site.
Right.
If it is a bulky disease to begin with, say when you started a nodal mass in mediastinum or retroperitoneum, and after you have completed, patient is in CR, you radiate it. Or if there is a small residual one. Now, why it is not important? Because extranodal site will be in any of the solid organs, like in gastric, in lung and all. So radiation is a usual practice for solid tumor of these organs, like radiotherapy with chemotherapy is main treatment for gastric cancer or esophageal cancer.
Right.
So giving radiation to these organs is not difficult. Rather, it is much more common.
Absolutely. Thank you so much.
Thank you, Dr. Sangeeta. Gaurav, can I stretch this?
Yes, sir.
Will a EOT PET scan and the Deauville score make a difference in your decision of additional radiotherapy versus no radiotherapy?
Sir, as of now, we don't have clear data to suggest that. Nobody is running those trials. Maybe radiation team or us should run this.
Yeah, actually, we have started one RCT. I mean, we have just started recruiting. That will be for DLBCL who have received 6 cycles of R-CHOP and had either bulky or extranodal site, which were the current indications of RT, I mean, consolidative RT till now. And then they will have CMR. So we will randomize them into 1:1 into RT versus no RT. This is because, recent that British Columbia trials, which kind of suggested that if the end of chemotherapy PET is CMR, you can avoid RT irrespective of bulk or extranodal. So we are starting. Let's see what it shows.
So if you see overall, the role of RT is gradually, reducing in the field of hemato-oncology. Hodgkin lymphoma is a point in case where less and less RT is shown to be beneficial. I think it's more pronounced in Hodgkin lymphoma because the kids or the younger individual are more prone for RT-related, adverse events. So people were more concerned there. But in DLBCL also, so most of the data of giving RT after CR was in CT scan data, as you said. Now, Professor Agrawal asked this question that if PET is in, say, Deauville 1, will you give it? So we don't have, sir, data to say that we will not give. What we are using it, we are extrapolating from our understanding from the CT scan era time. And but currently, if you ask me, sir, I will give.
One question to Sangeeta.
Yes, sir.
Trial, if your EOT PET scan is positive, Deauville 4 or more.
Yes.
Biopsy included before they are giving radiation?
So we will include only the patients who have CMR. If the patient is not having CMR, meaning Deauville's 4 or 5, that patient will not be a candidate for the trial.
So only up to Deauville 3?
Only up to Deauville 3.
Right. Because sir, 4 and 5 will anyway have indication for our radiation.
Yeah, and we were scared the result will be, biased by including the Deauville's 4 and 5. So it will be purely CMR patients.
Yeah. Okay, Dr. Akshaya, your question.
Thank you, sir, for the wonderful talk. Sir, I am a hematopathologist and recently I have received a staging marrow in case of gastric lymphoma. And on flow cytometry, I'm getting no B lymphoid cell and patient has not yet received any treatment. So the paucity of B lymphocytes in a staging marrow, is it clinically relevant in any way?
Paucity of B lymphocyte in a staging marrow, and you said patient is having a DLBCL.
Yes, a gastric
DLBCL. So I will answer from clinical perspective. clinically, what current today is relevant is whether the malignant cells are there within the marrow or not. So either if you can demonstrate on sections of bone marrow or by flow cytometry that malignant B cells were there in the marrow, then we will take it positive. Now, whether something has happened to B and T ratio within the marrow, it will not have any bearing on clinical decision making as of today.
Okay. Thank you, sir.
Akshay, how do you define that paucity of B in the marrow?
Sir, actually, we have gated around 30% lymphoid cells, and in that 30% lymphoid cells, approximately 80% cells were T lymphocytes expressing all the T cell marker with 4:8 ratio equal 4:8 T cells, and the remaining 20% cells showed CD56 expression with negative expression of CD3, and they were all fitting well with the NK cells. But on gating the lymphocytes, we are getting no CD19 positive or CD20 positive event.
All right. So now doctor, no raise hand sign, but we'll go to the audience now. So we'll discuss primary mediastinal large B-cell lymphoma. I have a question regarding that. You gave an explanation for why checkpoint inhibitors work in Hodgkin. That was wonderful explanation. What about mediastinal large B-cell lymphoma? Why does it work?
Yes, sir. So mediastinal large B-cell lymphoma is a slightly different from DLBC, general DLBCL, nodal DLBCL, and because it starts from B-cell of thymic origin. So now I am at shorthand to kind of give that molecular interplay, but thymus is a site of T cell, and it is a site where T and B cell interaction takes place. So it is my thought process that most likely in that thymic origin B cell tumor, the immunological profile might favor because the data is there that immune checkpoint inhibitor help PMBCL apart from Hodgkin.
Right. The question is, what is your protocol for mediastinal large B-cell lymphoma?
Yeah, so mediastinal large B-cell lymphoma, we use a young and fit patient with a dose-adjusted EPOCH-R. And otherwise, we used R-CHOP chemotherapy with radiation as consolidation later on, if it was bulky.
And if you have used DAR EPOCH and the interim PET scan after 4 cycles is positive, and then you've gone on to do the 6th cycle, and if the positivity persists, and then in this patient, they had excised whatever was there, and the biopsy did not show that there was any residual lymphoma. Now, what do you do?
So for PMBCL, such kind of instances will be rare. But if you have very conclusively shown there is no residual tumor, that means it is a pathological CR. And after the patient who develop pathological CR have the best outcome. Even if interim scan was positive, I will observe this patient.
So Deauville 4 biopsy negative, no radiation.
No radiation, sir. Yeah. You said excision, sir, not biopsy.
Sorry, excision. You're right.
Biopsy is if it is a PET guided biopsy and taken from the most avid area, and if that is negative, then because we know in PMBCL there can be a residual mediastinal fibrotic nodule. So if I am deciding on PET biopsy, it has to be PET guided from the most representative area. If it is negative, we can avoid radiation.
Right. Do you ever use R-CHOP for mediastinal large B-cell lymphoma? And if yes, then do you always give them post-treatment radiotherapy?
Yeah, so I'm unable to remember, but there was a paper which said that even after R-CHOP chemotherapy in complete remission patient, you can omit radiotherapy. But as of now, we treat the patient who received R-CHOP chemotherapy because most of these patients present easily with a more than 7.5 centimeter. As I said in the initial part of my discussion, that I still follow giving IFRT to bulky disease at the baseline. So from that interpretation also, R-CHOP treated patient after remission will receive radiation therapy. Now one thing is like, again, we talk on precision medicine. If there is an unmarried young female, because PMBCL is more common in women, and there are risk of breast cancer subsequently, those points will always come up in discussion and assessment, but in general, answer is yes.
Right. There are questions related to now polatuzumab. One is that there is no survival advantage. So do you still recommend pola-based therapy for some people?
I would recommend recommendation. When I say I would recommend, I am taking this understanding for granted that those patients can afford it. I never push for
No,
polatuzumab.
forget the cost. Just the sample.
Right. So here, I think because I think the connotation of the question was on those lines. So since if OS benefit is there, then doctors can probably be more persuasive for the therapy. But if OS benefit is not there, and if you see the benefit of Pola RCHP was more in patients who were older, who had activated B cell and who had IPI poor risk, high risk IPI. So that subgroup of patients do very poor with R-CHOP chemotherapy. Now, if Pola CHP can be given, so I will definitely recommend, because EFS advantage in that population 6 to 7%. Now, if elderly population, you do not treat any malignancy the first time, then you probably will not get a second time. So today the patient is say 65 or something, and with R-CHOP after 3 years they relapse, it is 68 or 70. So therefore, if the patient can take it, it is recommended.
Thank you. The other question is that you discuss right up to NGS in DLBCL. In practice, what all do you do?
So very important. So nobody does NGS on DLBCL for decision making in the world. The data I showed you is, the upcoming phase of precision medicine which is coming in. All those 7 genetic subtypes are part of research work and which is published. But then the way activated B cell, so we knew CD20 in 1980s, but rituximab came in 2000. We knew cell of origin way back, but then this DA-EPOCH-R came later. So something like that. This is something we now know that 7-8 genetic subtypes are there, but there is no need for us to send sample to know which genetic subtype is there. In times to come, as I told you, from gene expression profiling, now we have Lymph2CX platform, which is simpler. So more and more simpler platform and AI models will come. And at that time, probably we can send our initial baseline diagnosis for genomic stratification.
So the question is, at the moment, what are you doing in India which impacts your treatment?
So I think my last slide was the same. I showed you very clearly that how we should go. So the drugs that we have, which are effective, are ibrutinib, lenalidomide, polatuzumab, and bortezomib to some extent, although bortezomib benefit was not there. So these are the drugs which you can play with in frontline setting. In relapse setting, it is a field day. You decide whatever best you have and you give it to the patient.
So in short, you will do the FISH studies and stop there, right?
Yes, sir. FISH studies at the beginning, if you have to decide for dose intensification. But for example, if I am working at a center where possibility of dose intensification with DA-EPOCH admission and all those things are not available, I will skip FISH part and we will just go. The second part is availability and turnaround time of FISH. If it is in-house available, you can get it early, then probably go for it. Because double hit and triple hit will be 6%. You can't wait for rest 94% who will not have double hit lymphoma. So therefore, that is the reason that most centers are not doing FISH in the beginning because of cost effectiveness, turnaround time. One way is that you start treatment with R-CHOP with everyone and send FISH. And if it turns out to be double hit or triple hit, then you from subsequent cycle may intensify further therapies.
Fair enough. There are some related questions which talk about that if you have ABC versus GCP, is it impacting your treatment decision? So one you mentioned about poly. Any other?
Yeah. So that is ibrutinib, because ibrutinib is very effective. In the Phoenix trial, ibrutinib was effective. The main problem with ibrutinib is the standard one is the toxicity in elderly. So definitely, if somebody has either cardiac illness or somebody is more than 60, you can stay away and treat with R-CHOP or any other combination. but ibrutinib ABC subtype. If your question is for our ACBVP, which is the LNH03 trial, that combination is is like BACOP for DLBCL. We all of us, have seen excellent data, HD21 trial, SD10 trial that BACOP is, way above, but very few use it. Same way is that protocol. And that is one protocol of conventional chemotherapy which showed overall survival advantage, but it is not being used. I have never used it.
Right. There are a few questions about interim PET scan. Is there a place and how does it impact your decision making in DLBCL?
So as of today, it is only data collection. We have been collecting this data for quite long. PET-adapted therapies could not find a place for DLBCL. So if there is a possibility that doing an interim PET may delay next fifth R-CHOP or fourth R-CHOP, then you drop PET scan and give therapy. I will be that straightforward in this point at this point. So some in my hospital also sometimes I see that students, they just kept waiting for PET, and PET at sometimes 1 mahina, 2 mahina ho jata hai. So absolutely not. If you can pre-plan it date-wise and get it done within that window, then you get it done. But it's just going to prognosticate your patient better.
So other related question is, with the availability of CAR T, if your interim PET is positive, will you move that patient to CAR T status?
No, not yet. We are not there yet. Only at the time of relapse, if patient is there, then that is a time I will consider CAR T, a possibility of whether the trial is available, of the patient can get it.
Okay, again, there are related questions about how do you select between auto transplant versus CAR T in a relapse setting?
Okay, so there is absolutely no study which has compared, and it is very unlikely that there will be any study which will compare them in a randomized or phase 2 fashion. So there is no comparison. Auto transplant is available in house. You just take the cell out, give chemotherapy, and you are done. So if now in this hypothetical situation, I have to choose between the two, I will give salvage, DHAP, ICE of your choice. If the patient remits, I know it is a very chemosensitive, conventional chemotherapy sensitive relapse, consolidate with autologous stem cell transplant. But if after 3 or 4 cycles of salvage also the patient has a residual disease, then it is conventional chemotherapy refractory, and we need a different way of killing these tumor cells. And probably if CAR T is available or patient can afford, that is my personal approach.
So blanket treatment salvage to everybody, and if it is not chemosensitive, then CAR T. All right.
Yes.
Arihant wants to know about maintenance therapy in a poor prognostic DLBCL, lenalidomide or ibrutinib or anti-CD20 based. If you have a data of high IPI or double hit DLBCL, and you know that the chance of treating relapse is very, very remote, so will you give them one of these maintenance therapy, lenalidomide or ibrutinib or anti-CD20?
Yeah. In day-to-day practice, sir, I do not use maintenance therapy for DLBCL. But if I have to use for the patient Arihant just mentioned, then probably lenalidomide is the drug. 2 reasons. Number one, we have very good experience of using len as a maintenance for myeloma for 5 years, 8 years, even that much. And the second one is that in one trial, it showed PFS advantage. Rituximab maintenance, no matter how much we would want, but it did not show benefit and only increased risk of infection. It is more injectable every time patient needs to come. So all those len probably yes in very selected cases.
And Gaurav, that trial for len was only showing in elderly people, right? Advantage.
That's what I will have to check. I remember from my background thing. Yeah.
Fair enough. Now, you have advised IBRU in a select group of ABC young people. So will there be some place for maintenance there for IBRU?
So since it was not used, I will go with the trial protocol. So no maintenance, we'll stop with therapy.
Yeah. Dr. Sundar has a question about, is there a place for ctDNA in monitoring, and is it available?
So this is the ongoing research. What you call is like ctDNA, circulating tumor cell liquid biopsy. We are also researching at PGI this thing, that circulating cell-free DNA, and to find out whether it reflects the response. So to answer in short, it's in the realm of research. Many groups are working on it, but as of now, we do not make therapeutic decision on the basis of presence or absence of circulating tumor DNA. Colon cancer is one tumor where this has come up, especially in metastatic colon cancer, but not in DLBCL.
Okay. Sundar Shevale wants to know about glofitamab. Where do you fit in? And what is its future? Where do you use it today?
So glofitamab, tafasitamab, and so initially I was thinking that I will include them here, but most of them are mainly approved for relapsed refractory DLBCL multiline. And the second reason was they are not available and we need to import them. So they are in the realm there. As of now, we are not, kind of precision or molecular target guided. They are not being used. Like tafasitamab CD19 is a pan B cell marker. So relapsed refractory setting, sir.
Sure. Chirag has a question. What are your thoughts on clonal lymphopoiesis of indeterminate significance?
Yep.
Can you put CLIP as predictive of future progression to lymphoma?
Okay, so CHIP is something which all of us are trying to understand, but then in future it can give rise to the most common is dysplasia and AML, and some solid tumor risk is higher the patient who are carrier of CHIP. At present, I am not aware of any association between CHIP and lymphoma. If any of you are aware of it, then let's share and discuss it. I'll be happy to learn.
Yeah, so he has used a new terminology, CLIP, clonal lymphopoiesis of indeterminate significance. Moving on to the next question, Babita Sodi. As shown in one of your slides on double hit lymphoma GCB type, double expressor as ABC type.
Correct.
As GCB has better prognosis than ABC, my query is whether it is true of double hit to be GCB type. Actually, it should be other way.
Yeah, so a very good observation, but then I understood your confusion. Luckily for all of us, that double hit cohort is 6 to 7% only. So if you take GCB subtype, if you take all lymphoma together, 60% will be GCB, 35% will be ABC, and 5% will be unclassifiable. Now, if you fit that 6% into GCB cohort also, it makes only 10% of GCB. So therefore, the poorness of their outcome has limited bearing on the whole cohort of GCB, and in general, GCB have really good outcome, and RCHOP also is sufficient for them.
One last question in the chat box is, as POLA has been approved for all the DLBCLs of high risk type, would you really select out somebody or give to all with high IPS score?
So I will speak of my practice. It is approval is there, and it is the now clinician's job to assess a particular patient. As I told previously also, POLA is something which is which has shown maximum benefit in elderly patients and the patient who are having these poor risk profile. Now, polatuzumab is a drug which is MMSC, vedotin, and which causes significant neuropathy. Cost is also a very important aspect, but then if for a moment we keep it abeyance, then if you have a patient which is, I guess, 65, 67 with diabetes, with some possibility of neuropathy, and they're gray zone, because what we are achieving is PFS benefit. So I probably decide not to. And in day-to-day practice, affordability is very important. You are getting 7% PFS benefit, but at what cost? If it is costing you your annual take-home income, then probably this is a doctor's job to assess and advise your patient. Patients know nothing what is polatuzumab. So my answer is very selective, and most of the time the selectivity comes from patient affordability and fitness profile.
Right. I think with the discussion on CAR-T, I opened Pandora's box. There are questions pouring on CAR-T. With Zuma 7 and Zuma 12 data available, how do you avoid CAR-T therapy in first-line therapy, bad prognostic DLBCL, second-line therapy before autologous transplant?
Right. So there is a different realm, cell therapy, but show me a date if you do a trial where frontline treatment with the conventional chemoimmunotherapy versus treated with CAR-T. In the down the lane, it will come. Now we are moving toward chemotherapy free for Hodgkin lymphoma, only BB and Nivo as no chemo. So therefore, it will come. But today, as of now, definitely, as I said before, it is placed for relapse DLBCL whenever it happens.
Okay. Gopinath, you removed your raise hand sign. You want to ask? Meanwhile, Amit has a question.
Sir, a fantastic talk. I have a doubt regarding if the patient is already given Pola RCHP 6 cycles, and if you see the data of the polaric study, they have to really do well in the bulky disease also. The patient has got already a disease bulk. You are already given 6 cycles of Pola RCHP, PET is negative at the end of treatment. Are you still justify giving post RT to the bulk?
Yeah. So as you said yourself, that post consolidation RT is not studied in the era of precision medicine and newer drugs. So we really do not know what to do and where to use. But if I say that we borrowed conviction from the previous existing data, and I will again repeat the same thing, which is a very practical point, that maximum chance of cure is in the first time of treatment. If I had a doubt that patient had aggressive disease, patient had bulky disease to begin with, and radiation can be delivered with a relative safety, I will talk to my radiation expert. Then even after Pola CHP, it can be given, because the principle of radiation is different. It has never been tested. So with BTK inhibitor, now we are using more Pola R. We are using dual targeted therapy, Pola and R. So it is an open thing, but individually, as I told you, is a borrowed knowledge understanding from the previous one. I don't know the answer.
Okay, thank you. Another question is, if the patient, you already mentioned about intercollecting the patients who have got high CNS risk feature,
Yeah.
methotrexate, high dose methotrexate. Suppose if I have a patient who have got DLBCL with adrenal gland involvement, and patient has got is about 58 years of age, are we not justified giving methotrexate at the end of therapy rather than intercollecting in between, because day 3 would not be too toxic?
Yes. So number one, since I use it intercalatingly in quite fit patients, it can be done. But it requires extra effort. You have to be on the toes. You have to anticipate more neutropenia, give more growth factor. And so the concept of dose density comes here. There were older papers, especially in Hodgkin lymphoma, which showed a significant difference in outcome where dose density was not respected. You know how it happens in our clinic. Patient came for ABVD after 15 days. TLC is around 2700, 2800. Junior resident saw it and found it low and sent the patient back. So it reduced the density, more gap. So therefore, it is I know many practitioners in lymphoma who complete it at the end of it. Since the data on primary CNS profile axis is very, very on very thin ice, there is no solid argument in favor of intercalated methotrexate versus intrathecal. So rather than doing nothing, I will recommend that if you cannot intercalate, give at the end of 6 cycle, additional 2 cycles. But then those 2 cycles should be at gap of 15 days, because whether you take ALL or primary CNS lymphoma, high dose can be very easily given at 15 days gap, not at 21 days.
Thanks a lot.
Thank you.
One question has come up about radiotherapy again. In a limited stage DLBCL, after 4 cycles of R-CHOP, if your PET is negative, you are not giving radiotherapy. Is that correct?
Correct. That is correct. I'm assuming it was not bulky. Limited stage can also be bulky. So if it is limited stage, non-bulky, 1A, 2A, LYSA trial data shows that 4 cycle R-CHOP and you observe this patient.
And if it's bulky PET negative, you will still give after 4 cycles.
Yes, sir. Yes, sir. You may call me biased towards giving radiation a bit. Like if it is bulky disease, then definitely I will offer this patient. But then it comes same thing, sir. A younger female, unmarried female, coming early with a bulky mediastinal early stage. So those are bedside decisions that we all of us make these modifications. But in general, if I speak, I will recommend, sir.
Are you doing that for Hodgkin also? Limited stage, PET negative?
Hodgkin data, sir, is very much clear now. Radiation, so we can. I'm more convinced in omitting radiation in Hodgkin lymphoma patient, especially younger patients, sir.
Rashmi, your question.
Thank you, Dr. Gaurav, for the wonderful talk. My query is that is there any diagnostic or prognostic association of any viral markers like associated viral infections, EBV, HHV, or HIV with DLBL? Should EBER be done in all these patients who have been diagnosed to have DLBL?
Yes, ma'am. So EBER-ish is there very important for B-cell lymphoma for PTLD. So much so that it helps to titrate your treatment and follow these patients, EBER-ish. Otherwise, EBV is very funny. EBV has a receptor for B-cell. It involves B-cell, but the most of the tumor it generates is T-cell lymphomas. So primary CNS lymphoma is another one which has association with HIV and EBV. So answer is, I mean, if I got your question correctly, then in DLBCL, there is no need of doing EBER-ish or in general, but PTLD, which is post-transplant immunosuppressed DLBCL, that is a unique biology tumor.
Right.
Can I make a comment?
Of course.
I don't know, I mean, if it is really established, but we have seen EBV positive DLBCLs, they do worse in outcome. Yeah, we have observed that. They do worse in terms of both response. I mean, most often they do have residual disease and also in terms of relapse. I mean, but this is just a clinical observation. We are yet to collect.
Yeah, I understand. But then how did you find it out? I'm curious because in general, we do not send either DBB and do not perform EBER-ish. So was it a thesis protocol in which you studied or is it a part
recently, I mean, because we have seen EBV positive DLBCLs more in elderlies. So elderlies with little bit disseminated disease, short duration, EBV is being done nowadays. It was, yeah. Okay. But I mean, this is just just a clinical observation. We are yet to collect the data.
So I think you highlighted a very important point. We will be able to answer only if we come together. Otherwise, I will have experience of say 30 EBV positive DLBCL. You may have 40, but individually it will mean very little.
Does it have any effect on the prognosis if we talk about association of EBV?
So as I think Dr. Sangeeta spoke, and she said that she found in her small series. So we have to study this systematically. As of now, EBV is not one of the established prognostic biomarker for DLBCL.
On this subject, if you have DLBCL cutaneous leg type, EBV positivity has a prognostic impact?
That I do not know because that is a very rare subtype of DLBCL. Yeah. I do not recollect offhand at the back of my hand. I will read and tell you.
And deviating from the subject, in T cell, when you have EB positivity, what is your impact on the treatment? Do you make etoposide compulsory? Directly asking one question.
No, sir. No, sir. Etoposide benefit in that randomized data is for ALK positive ALCL. In others, we give etoposide. And if there is a one unique situation where AITL-like or EBV-related HLH is there, then etoposide may have additional value. But that is a post-hoc decision in a case-to-case basis. If anybody has another view, then please express so that we learn together. Sir, you can give your thoughts, sir.
CD30 is positive and you're using brentuximab-based protocol where there is no etoposide. And if that patient has got EBER positivity, does addition of etoposide, making it quite complex, BV plus CHOEP, does it make a difference in the final outcome? There are some small studies, but of
Okay.
course it may not make a standard of care.
Okay. Okay.
No more question in the chat box. Yeah, nothing has come up.
Great.
No raise hand sign here. So I think it's time we allow you to go away. Enjoy your rest of the Sunday with your family.
Thank you.
Wonderful. You made it very attractive, very knowledgeable, fantastic QA session. Thanks to the audience to put up so many questions for Gaurav. They were thought-provoking. And thanks to Dr. Rashmi for sparing her time to be our chief guest, and a
Thank you so much, sir.
great message you gave. And thanks to Amit Khurana and all other people over here for sparing your Sunday. Thank you so much. Enjoy with your family. Bye-bye.
Bye,
Thank you
sir.
so much.
And thanks to you for organizing and being a very relentless teacher, sir.
It is all selfish motive of learning myself.
Okay. Bye, sir.
Goodbye.
Yeah.